Now I'm very pleased to present to you a speaker from the United States, from Dayton, Ohio, Jerry Mallicoat of Dayton, Ohio, public health educator and project manager for LGBTQ Health Initiatives at the Public Health Dayton and Montgomery County. He's a survivor of HIV and also early suspected he might have had COVID-19. He can explain his situation. But anyway, we're grateful, Jerry, for you to bring us a perspective from the United States and to share your professional and personal experiences.
Thank you, Don. So, as Don mentioned, I live in the United States. I live in Ohio. And for those who may not be familiar with the geography of the United States, Ohio is as part of what they call the Midwest. But I live and exist in East Coast time, Eastern time, if that helps anyone to sort of define where I live. As Don mentioned, I work for the local public health department, Public Health Dayton and Montgomery County in Ohio, which is in Southwest Ohio. And I lead LGBTQ Health Initiatives. That's lesbian, gay, bisexual, transgender, and questioning or queer health initiatives, because we know that there are a number of health disparities that exist in the LGBTQ community, largely as a result of social determinants of health that have marginalized the community for decades and longer. And I also am a co-founder of an organization called Rainbow Elder Care of Greater Dayton, which focuses on affirming the lives of older LGBTQ people, because we want to thrive just as we did when we were younger. And so there tends to be little focus on older LGBTQ people because we have such a youth-oriented culture. In my work with public health, I became concerned very early about the impact that COVID was having on the LGBTQ community, because, as you know or may know, sexual orientation and gender identity cut across all races, all socioeconomic strata, all religions, all abilities. And so as we began to learn that coronavirus was impacting communities of color, African Americans, other people who identify as Black, Latinx or Hispanic communities, became concerned that we wouldn't know the full impact of coronavirus on LGBTQ people who also identify in those communities, the Black or African American communities and the Latinx communities. And true to form, my fears were confirmed, because what we saw very early in relation to something that Don mentioned at the outset of the webinar here today is that data capture was woefully inadequate, as it often is when it comes to sexual orientation and gender identity, for a variety of reasons, largely related to stigma. Healthcare organizations and others don't think to ask or won't ask about how a person identifies in terms of their sexual orientation or their gender identity in relation to the sex that they were assigned at birth. And so often LGBTQ people, their full identity isn't captured. So we will never know the full impact that COVID has had or will have in the LGBTQ community, because the data isn't being captured. And so what I did at Public Health in that regard is I worked with our epidemiology department to develop a survey that I worked with some of my colleagues in the local LGBTQ community organizations to push out into the community to try to capture at least some data about people who have had COVID diagnosis, or to try to capture information about people who have died related to COVID. Now, that's gotten a little bit of traction and a few respondents, but it will never be as robust as having questions about sexual orientation and gender identity like other demographic data such as age, race, or ethnicity on an official form that is provided by the health department or the Centers for Disease Control or other healthcare organizations. So all of that aside, there are some impacts locally here in Ohio and the United States that COVID is having on the community, and in particular, people with HIV and AIDS. This is who I am. You can see all my official titles, but then also this is a photograph of, this is me here with one of my colleagues out doing pop-up COVID testing. So the public health department periodically will do what we call pop-up testing in various locations around the area. And typically the locations are ones that we are monitoring where we know that we've had spikes in coronavirus, or that would be more prone to coronavirus given what we know about the various demographics and their vulnerability to the disease. So I'm going to just back up here and just review a few things. I apologize for the flutter of the slides there. Most of these facts are things that Don talked about when he opened the webinar, about the fact that people with HIV aren't necessarily, in the United States anyway, more vulnerable to COVID, but if they aren't in treatment and care and they don't have the HIV virus suppressed in their system, it could put them at greater risk for coronavirus. And there are a few things that are important. If you do have an underlying health condition of some sort, in addition to HIV, that could be something like asthma, diabetes, some sort of heart condition, and a few other types of conditions, chronic conditions like that. It could put you at greater risk. And we always try to be sure that we recommend people have at least 30 days or more a supply of their antiretroviral medicine in their home. But what we've seen is getting medicine to remote areas, even rural areas in the United States, can be a challenge for a variety of reasons, including delays in the mail system, the ability to get appropriate quantities of medication, et cetera. But the things that really are impacting people living with HIV and AIDS here where I live in Ohio and in the United States, as I mentioned, there's a greater impact in the Black and African American and Latinx communities. And we know here in our country that these same communities have a higher prevalence of HIV and AIDS. Most of the new diagnoses of HIV occur in these communities. And so because also of decades of marginalization and discrimination, many of these communities are socioeconomically challenged. And because of that, sometimes access to care, healthcare is a problem, and that results in chronic and acute health conditions. The inability to engage and interact in a virtual world to obtain telemedicine has been a big issue. We've heard a lot about how telemedicine is being implemented to take the place of a physical visit to the doctor or to the hospital. But the problem is that if you don't have the money to afford Wi-Fi, or maybe you don't have a computer or a laptop or even a cell phone, telemedicine becomes pretty difficult. And what we see locally is that many people living with HIV and AIDS don't have access to all of these things, which makes it more difficult for them to get the care they need, and obviously isolates them in many, many ways, not only from healthcare, but also from their other support networks of friends, family, etc. Many have the inability to travel for care, and that creates greater isolation. And we know that isolation breeds all sorts of other types of mental health issues, and can definitely impact your physical health as well. One of the issues that also exists within the HIV and AIDS community here in Ohio is challenges with contact tracing. So one of the aspects of trying to contain coronavirus, much like existed when AIDS first emerged, back in the 80s and the 90s, was tracing contacts of people that someone who has the virus has been in contact with. And so that is a challenge here with coronavirus as well, especially in some of the marginalized communities where people living with HIV and AIDS exist. Because typically most people are communicating via a cell phone. So not everyone has a cell phone with unlimited data and phone usage. Some of them have what we locally call burner phones, or phones that don't have a lot of time on them and data capabilities. So being able to trace contacts, track people down so that we can talk to them and find out who they've been in contact with becomes a challenge. And because of the distrust of public health departments that has emerged over decades and decades, including during the AIDS crisis, it's difficult sometimes to get people who have coronavirus or may have been exposed to someone who has coronavirus to talk with us and to share all the necessary information we need in order to try to contain the spread of the virus. And then, of course, there are cultural and language barriers that exist here in Dayton. We have quite a refugee and immigrant community here. And of course, many of those people, when they arrive in our community, they come through public health in order to get proper immunizations and so that we can connect them to proper care in the community. And cultural and language barriers are difficult to begin with. But when you layer in something new, like a coronavirus during a pandemic, those challenges become even more insurmountable sometimes. And as I mentioned earlier, the lack of data capture, especially for LGBTQ people. Again, most official forums that are being used through state health departments or even through the CDC, the Centers for Disease Control, do not capture sexual orientation and full gender identity data. So again, you may never know the full impact of coronavirus in the LGBTQ community. Just some quick stats here in Ohio, the state where I live. We have a system of an advisory system of levels of outbreak of the virus in Ohio. You can see them here in the upper part of the screen. So, we have level 1, which is the lowest, up to level 4, which is the highest. And the county that I live in is here with the red circle. That's Montgomery County. And we're getting better at controlling the spread of the virus here, but for a while we were at level 3. And level 3 is considered very high exposure, and a lot of extra precautions and actions get taken when you reach level 3. These are the stats for the numbers of cases, hospitalizations, and deaths in Ohio. So you can see here we've had 151,000, almost 152,000 cases as of September 28th. Likewise with hospitalizations and deaths. In the United States, we have about 206,000 deaths from coronavirus, and we're approaching soon 7 million cases of coronavirus in the United States. This is the county where I live, and this really just reinforces the comments that I made earlier about the disparate effect that coronavirus is having on the African American community in particular. And these are stats for my county. So you can see here our total number of cases is about 10% of the total cases in Ohio. But if you look at how the data break down in terms of Black people identify as Black, the rate of infection is 1 in every 53 compared to white, which is 1 in every 102. So, almost twice the rate of spread and infection of coronavirus among the African American community or Black community. And this chart here just sort of reinforces it here that the disparate impact of the virus in the Black community, given their percent of the population. The darker bar is the percent of COVID cases. The lighter bar is the percent of population. So this was much higher, I will tell you, but because we have a couple of universities in the area and college students have come back to school, and most of the students are white students, these numbers have shifted over the last month or so. As college students have come back to school, the cases have spiked in mostly the white college and university community. Something that I will talk about here quickly, Don mentioned the fact that I had a little scare with what I thought was coronavirus back in the spring, just as the virus was starting to have an outbreak in the United States in early March. I developed what I now believe and was told was flu A, but it was the worst flu I've ever had in my life. And many of the symptoms that I had were very similar to the symptoms that you hear about with coronavirus. Spiking fevers that you think are under control and then learn that they aren't. Tremendous fatigue, trouble breathing. I thought maybe I was developing pneumonia. So it took me a week really to get through some of these symptoms. In the meantime, I was in communication with my doctor trying to determine whether or not I could get a COVID test. And at that time in March, even though I'm living with HIV, I was not able to get a coronavirus test. My doctor could not order one because they wouldn't give it to him to give to me. And so I started having sort of PTSD-like flashbacks to the 1980s when I first learned that I had HIV. And there were so many similarities in the way that the testing and the screening and the government's response was to coronavirus that it was reminding me so much about, when AIDS first emerged. And in this country, in the United States, it wasn't even known as AIDS originally. It was known as gay-related infectious disease, or GRID. And so I really was sort of having panic attacks about it. And you can see here, there is something called AIDS survivor syndrome that is emerging in the science now. And some of the symptoms that I was having were, sort of, I wouldn't say I was suicidal, but I was having panic attacks. I was worried that I was isolated. I was angry at the government, much as I was back in the 1980s and the 90s, because they didn't seem to have any plan or to have a grasp on the situation or to be responding to it quickly enough. And of course, I was trapped at home watching TV and seeing case after case after case of people getting sick and dying. And it was very disturbing to me. And I just put this slide up here so that you can see some of the emerging research around what they call AIDS survivor syndrome, which some people, I guess, today would say there are certain triggers that will trigger physical, mental, and emotional reactions to things based on the experience of living through the AIDS crisis. And I definitely was experiencing some of these, back in March when the pandemic was first hitting the United States. So here where I live, and I think across most states in the United States here, we are trying to get a better handle on the virus. There have been some fundamental things that have been missing in our approach. We did not have good universal testing initially, and we still don't have great universal testing. There were confusing messages about universal precautions, wearing things like masks and gloves, and how to properly sanitize. And because of those that kind of confusion and lack of equipment and testing that we needed. Essentially, the virus got ahead of us, and we've slowed it, but there are still concerns about whether we're going to see spikes as the weather turns colder across most of the United States and people are forced back inside where they can't socially or physically distance and are in environments where the virus would tend to spread, places like schools and universities, etc. So I hope that that's been helpful in some sort of way. Speaking as someone who was living with HIV and AIDS, when this first broke out, I was scared. And I learned later and read some things that there was some sort of comorbidity between flu A and coronavirus, excuse me. I did get tested for coronavirus several months ago, and the test was negative, so I don't have any concrete reason to believe I actually had the virus. But not knowing and uncertainty in the midst of what can be somewhat of a panic without proper plan, without proper equipment, without proper procedures in place, the pandemic just can get worse and explode in a variety of ways. And one of those ways is obviously with your mental health. So just as much as we need to take care of containing the virus and protecting our physical health, we also need to, excuse me, be aware of our mental health and take time to take care of ourselves mentally as well. Taking breaks from all of the news about the pandemic, finding ways to safely spend time, excuse me, with things that you enjoy, whether that's your pet or nature or music. All of those things are important. And where you can do it safely, perhaps spend time outside or appropriately physically distanced with people that you love. Because if one of the things that the pandemic has taught us is that we aren't guaranteed of time. We aren't guaranteed of tomorrow. And so we need to make today count and be the best person we can be today, physically, mentally, and socially. And that requires us to take care of ourselves. And part of that is your spiritual health as well. However you define that, excuse me, it's important to remember to take time to take care of yourself spiritually. So thank you for the time. And thank you, Don, for including me.
Thank you, Jerry. You did make today really count, because what you've just shared with us is profound and poignant and truly on the cutting edge of information that all of us need. And I hope others will benefit from it, just as I have benefited from listening to what you have said now. Your presentation correlated very closely with what Bishop Catherine said from Kenya, from a different perspective and a different way, but the two certainly intersect.